Commonly used medicines in CTDs. Today, we'll talk about the common medicines used in connective tissue diseases, or CTDs. I'll walk you through condition by condition, explain why these drugs are used, and give simple examples. Number 1, systemic lupus erythematosus, SLE. The backbone drug here is hydroxychloroquine. It reduces flares, protects skin and joints, and improves fatigue. Almost every lupus patient should be on it long term. Example, a young woman with photosensitive rash and joint pains. HCQ helps keep her stable for years. For pain and serositis, NSAIDs can be used, but avoid them if there's kidney disease. Steroids are the fast-acting rescue. For severe flares like lupus nephritis or brain involvement, we use IV methylprednisolone pulses, then taper with oral steroids. Immunosuppressants are added to spare steroids, azathioprine for maintenance, mycophenolate for nephritis, cyclophosphamide for life-threatening disease like CNS lupus. And finally, biologics like belimumab or rituximab are used in resistant cases. Number 2, systemic sclerosis or scleroderma. The biggest problem is blood vessel disease and fibrosis. For Raynaud's phenomenon, the first-line drugs are calcium channel blockers like nifedipine. In severe cases, we add sildenafil or bosentan. For skin and lung fibrosis, drugs like mycophenolate, methotrexate, or cyclophosphamide are chosen. If the patient develops a renal crisis, the life-saving drug is an ACE inhibitor, such as captopril. Quick treatment makes a huge difference in survival. And because reflux is so common, most patients are on proton pump inhibitors like omeprazole or pantoprazole. Number 3, polymyositis and dermatomyositis. These are inflammatory muscle diseases. Treatment starts with high-dose steroids to quickly improve muscle strength. To reduce steroid side effects, we add methotrexate or azathioprine. In resistant cases, IV immunoglobulin is very effective, especially for dermatomyositis with severe skin disease. Rituximab may also be used in difficult cases. Number 4, rheumatoid arthritis or overlap CTDs. Here, the anchor drug is methotrexate. It slows down joint damage and is often the first choice. Other options include hydroxychloroquine, leflunomide, and sulfasalazine. For quick symptom relief, NSAIDs and short courses of steroids are used. If the disease remains active, biologics like TNF inhibitors, rituximab, or tocilizumab are started. Number 5, Sjogren's syndrome. The main issues are dryness of eyes and mouth, so we use artificial tears and saliva substitutes. Drugs like pilocarpine or cevimeline stimulate salivary flow. If there's systemic disease, hydroxychloroquine, steroids, or immunosuppressants are added. Number 6, antiphospholipid antibody syndrome, APS. The cornerstone is anticoagulation. Warfarin is used with an INR goal of 2 to 3. During pregnancy, we switch to heparin plus low-dose aspirin. In lupus-associated APS, hydroxychloroquine may add extra protection against clots. Number 7, mixed connective tissue disease, or MCTD. Here, treatment depends on the dominant feature. For example, arthritis may need methotrexate, ILD may need mycophenolate, and pulmonary hypertension may need sildenafil. Hydroxychloroquine helps in mild disease, while steroids are used for systemic involvement. So finally, Dr. Yogesh summarizes that hydroxychloroquine and steroids form the backbone of many CTDs. Methotrexate, azathioprine, mycophenolate, and cyclophosphamide are the main immunosuppressants. Biologics are reserved for refractory cases. And organ-based drugs, like calcium channel blockers for Raynaud's, ACE inhibitors for scleroderma renal crisis, or anticoagulants for APS, are equally important. The goal is simple: control inflammation, protect organs, minimize drug side effects, and improve quality of life.